Yeah. Thanks,
Right.
Andrea, for this opportunity. Really appreciate it. It's much better than when people ask you for a bio and you like spew all the wonderful things about yourself, thinking they're not going to read it verbatim, and then you're like, all right, that's kind of enough. I thought this was between us friends, right? So, just as a little background, Andrea and I met at a Google public sector event in Chicago, and got to talking about some of the work that we're doing, and thought this would be a good forum for this. It's my first time coming on to this meeting as well, but certainly not my last. And I, again, really appreciate the opportunity. And the last slide I'll show will have my email address. We are open to conversations on any and every level around the work that I'm going to be discussing. So again, thanks for the opportunity. And without further ado, I'm going to get going. Oops, Andrew, it's not letting me share. Let me just try this. I sent a
There we go.
request.
I think there
Okay.
we go. Yep.
All right, wonderful. So I'm going to share now. Hopefully, you guys will see the screen that says real world applications, not the picture of me proposing to my wife, which is in the background. Let me see if I can get that going. Can you guys see that? Or is it not showing?
Yep, you're good.
Okay, excellent. All right, and for curiosity, that's the picture of me proposing. Here we go. All right. So we're going to talk about real world applications of AI to advance public health, and just showing, the usual disclosure slide, but a lot of this work is supported by a mixture of grants from NIH, American Heart Association, and the Michigan Department of Health and Human Services, as well as from philanthropic support. And for completeness sake, I do some consulting work, but it's unrelated to this. And so our journey in this whole conversation begins with this map right here. I'll explain what Phoenix is in a couple of slides, but this map here shows deviation from average life expectancy in and around the city of Detroit in southeast Michigan. And the city of Detroit here is circumscribed by a black line right here. There's 297 census tracts, which are depicted here. And there's Oakland County, Macomb County, Wayne County, Washtenaw, Livingston County surrounding this. And while the data haven't been updated, as most of us know, for life expectancy since 2015, we here show deviation from life expectancy at a census tract level in Michigan, which the average life expectancy, as it said, is about 77.7 years, almost 78 years. And as you can see, there's a lot of areas across Southeast Michigan, especially in Detroit, where people are dying anywhere from 5 to 15 years younger than the state average, which to me is the ultimate representation of public health travesty and something that obviously needs attention. We know quite well from many different things that healthcare itself, even though we think as providers, oftentimes we're the center of the healthcare outcome universe, we're not. Most of what happens to people is due to what happens outside of the healthcare setting. This graphic is an older one, initially done as part of Robert Wood Johnson Foundation funded work, but shows basically that 80% of health outcomes are due to what occurs outside of the four walls of the healthcare environment, even though access and quality to care are important. But obviously, behaviors, environment, and socioeconomic factors are critically important. So our journey begins here, trying to explain the previous slide and this one, combining information together into something that we call the Population Health Outcome Information Exchange, or Phoenix. And it's a unique way that we conceptualized approaching this problem. This logic model shows how we think about it, right? And some of this was starting to be developed before AI really took hold, but it's about input from various different data sources, publicly available sources, electronic health records, other ways we can generate community data from screening events, mixing it all together into some mechanism of integrating data so that you can align things geospatially and temporally, so space and time. We initially started with Tableau, and I'll show that alpha version in a couple of seconds. But we ultimately ended up in the Google Cloud Platform in BigQuery because it had the ability to handle large amounts of data and then combine it with insights that would allow us to take in various data sources, as it says right here. iBio is our integrated biosciences center where the team that I oversee for this work is housed, and then allows us to produce outputs that can look at things like hotspots and targeting program interventions and analyzing trends and incidents and changes over time, all with an outcome goal of public health improvement through various different betters that you can think of for all of this. And so we started this work, even though this publication was in 2020, we started this work back in 2016, and it really was born out from the problem that we have where people are dying younger than they should in the city of Detroit. And I didn't show the graphic here, but nearly all of that is due to disproportionate impact of cardiovascular disease, heart disease outcomes, which traces back to high blood pressure. So we started getting some funding around all of this. I showed this concept initially in the state of Michigan. We have something called the Mackinac Policy Conference, which if you've been to Michigan and you've been to Mackinac Island, it's a small island that you get to by ferry just between the lower and upper peninsulas of Michigan. It's got no cars there. It's all horse-drawn carriages. So the island invariably smells like fresh summer breeze and horse poop, which is a good combination. But I presented the work up there, got some funding to support this, and then got traction in local publications like Bridge, Michigan, talking about how better data can help us figure this out. And we started conceptualizing a way to look at this data much like we would look at HIV data, and community viral load is a concept where you can know the average viral load in the community, mainly because a lot of the data come together through Ryan White funding, but you can know the average viral load in the community, and that can give you an indication of how well HIV is being managed in the community. We started to say, can you do the same thing with blood pressure? And so our first iteration, like I said, was to integrate blood pressure data from emergency departments. I'm an emergency physician, as was mentioned, by training, and I know a lot about what we do in the ER, but the one thing that we do on everybody is get a blood pressure. It's not always a perfect blood pressure. I've seen people with systolic blood pressures of 350 who are prisoners with their arm tied behind their back with handcuffs on fighting police officers. So we know that's not an ideal number. But most of the time, they're reasonable numbers to give us information so that we can conceptualize something called community pressure load. And so we started developing our Phoenix program initially as a hypertension dashboard. And this is our first iteration where we had almost 552,000 emergency department records where we average blood pressure, taking a geocode of the individual's address when they showed up the ER, and then putting the blood pressure mapped out by census tract. And our first effort at this showed the census tract, at least what I'm displaying here, in the location where Wayne State is, where the building I'm in right now is located, where over the course of about 26 months, we had almost 4,500 patient records with a mean blood pressure of 137 systolic, which is above the both diagnosis threshold for hypertension and the control rate for hypertension. And then we started peppering in different social and socioeconomic variables. You know, a couple of things will jump out. The median age of the community here is 29, and mean blood pressure is 137, so that's a really bad combination. The majority of households are below, at very low income levels. 61% of families are living in below poverty, 35% unemployed, 12% uninsured. So while that uninsured rate is high, it doesn't mean everybody is uninsured. And the life expectancy is lower at 72 years than the state average. Non-white population, 96%. Area deprivation index, which is like social vulnerability index as a summative measure, was the worst that it can be. So we started this road of how we can aggregate data, how we can start to make sense, at least in communities that we serve, from this data. And then the pandemic hit. And as it turned out, Detroit in the very early days of the pandemic was an epicenter for both COVID cases and COVID deaths. And we were perfectly primed to start to add on COVID data to better understand hotspots in our community. In this case, Sinai Grace Hospital, which was on CNN at different points, with bodies lined up, body bags in hospital rooms and what have you. And freezers out in the parking lot for serving as morgues and whatnot. But what we started to do early on was incorporate some of the data that we had been building up in Phoenix to say, well, why are people suffering so much from COVID in these areas? We couldn't necessarily predict why the prevalence was high, but we could certainly understand why mortality was high by looking at populations over the age of 65 and social vulnerability and density of nursing homes and whatnot. And not surprisingly, one of the hottest spots for COVID and COVID-related deaths was this area surrounded by nursing homes and aged populations and social vulnerability. And we included the social vulnerability index, which goes from 0 to 1 of 0.95, because the city of Detroit, if you use the typical value for what is considered high social vulnerability of 0.7, pretty much the entire city of Detroit falls into that category. So we really wanted to emphasize high social vulnerability. And so we set up the first testing sites in the city of Detroit back then. And initially, it was only for first responders and healthcare workers, as many of you guys might recall. And we tested about 3,000 police officers and firefighters and EMS and ER nurses and docs and what have you over the first 3 weeks. But based on mapping like this, knew we needed to get out into the community. So we started working with the Ford Motor Company. That's one of the advantages of being in the Motor City. You have ready partners like that. And the Ford Motor Company came and loaned us Ford Transit vans that we could start to take to communities based on this type of mapping for deployed resources, and quickly started doing COVID testing at scale in neighborhoods. The state of Michigan developed a racial disparities task force, and our work became a pillar of that. And we were soon able to get modernized vehicles where we could have, diverse groups of individuals. Not only is Detroit, a big population density center with one of the highest concentration of Black populations in the country. Dearborn, which is adjacent to us, is the highest density of Arab American populations in the country. So obviously, it's important to have diversity in the workforce if you're trying to convince people of things that you want them to do from a health perspective. But anyway, the state of Michigan, we started with philanthropic support. The state of Michigan started using CARES Act dollars to support this as part of the recommendations from a racial disparities task force that was formed by the Lieutenant Governor, Garland Gilchrist. Our work became a pillar of that, and the state started funding us to do various things, including expanding the mobile health infrastructure that we initially developed from our location. And we started doing things like taking maps of initially it was just testing, then it became vaccination. We started taking things like maps using our Phoenix data of COVID vaccination and started working with other mobile health partners to deploy to different areas of the community and target outreach for vaccination, and started showing effectiveness of our COVID outreach, right? By looking at something we call the Michigan Mobile Health Corps, which is our collaboration of mobile health programs in the area, looking at vaccine doses that we administered versus percent vaccine coverage increase, and starting to show the effectiveness of this type of outreach. At the same time this was going on, our Phoenix program started maturing. While we were in Tableau from the images I showed you, we moved over to Google Cloud Platform and created a website and had a fancy logo that we developed, and started incorporating many different databases, each of which could be aligned with different data elements from a clinical, social, built environment, natural environment, policy perspective. And then the region is it state, county, zip, tract, or block level. And each one of these data elements themselves have hundreds of data elements embedded within them. So we ended up having over 70 different databases that we incorporated with hundreds of data elements, and created a pipeline architecture where we could intake information, mix it together in BigQuery, create cloud storage buckets, complement it with research-related data that we pulled in REDCap, embed SAS Stata and other analytics in virtual machines right on top of that, and create an environment using OMOP as a common data model with geocoding and aggregated transformations to better understand our populations. And so we were really setting up the backdrop for ultimately layering AI on top of this. At the same time as this was going on, we started to reimagine our approach as going from pandemic response to portable population health, whereby we could take mobile units and not just focus on COVID, but start to focus on things that were contributing to disproportionate outcomes related to heart disease and heart health, things like high blood pressure and diabetes and smoking and high cholesterol. And at the same time, we started to advance our Phoenix infrastructure such that we went from data initially in Detroit to incorporating all of these publicly available data sets from Wisconsin to Massachusetts and states in between, so that we can start to get at geospatial analysis to do targeted outreach into neighborhoods. And Phoenix is publicly available. We have an IRB approved protocol that allows us to do disease surveillance with the aggregated data. And I have, like I said, a team of analysts that work with me on this. But we created Phoenix so that it would be a publicly available resource to help public health interventions. And so here just shows that if you go to the Phoenix website, which I'll drop in the chat when I'm done here, and even do a hands-on demo if you guys want, you can pick different data metrics, and if you gloss over this question mark right here, it will tell you the source of that data, and then you can see you can look for low to very high prevalence areas. But we also did embedded bivariate comparisons where you could look at things like social vulnerability index, matched up to hypertension prevalence, and you could look into the quadrants. And anybody who's in the upper right-hand quadrant here, which is very high hypertension rates with very high social vulnerability, is an at-risk population, right? And so what we could do is then tag any one of these circles, which represents a community, and that will take you right into the neighborhood that you're interested in. The next iteration of what we're doing with this is adding on Google Places data so that we can do asset mapping and understand what's in neighborhoods. And what we did from the portable population perspective is started using this as a deployment tool for mobile health outreach, and started getting additional funding through grants from NIH and American Heart Association, to the point now where we've done more than 100,000 encounters or so. This is only displaying about 82,000. Each one of these vehicles represents a deployed mobile unit for an event, and we've done almost 6,000 events by this time point. And you can see that we can target areas. In this case, the axes are reversed, but social vulnerability by hypertension, looking at different areas of the community, again, focusing on cardiovascular disease risk reduction through better blood pressure control and engagement. This one here just shows the number of blood pressures that we've measured in different communities. It says 13,000 here, but we're closer to 15,000 at this point. Again, seeing the overlay of where we're targeting outreach. We started publishing on this, right? We did some of the first work ever doing triplicate blood pressure measurement, which, if you guys are in the hypertension space at all, you know, triplicate is the most accurate way to measure blood pressure. You have someone sit for 5 minutes, make sure you're adhering to other aspects of standard, you know, blood pressure measurement protocols in the American Heart Association and the American Medical Association, and you can then do triplicate measurements, which take the average of 3 measurements, and they're unattended, so that the person can hit play on the hit start on the recording, and over 5 minutes you'll get 3 different measurements which are averaged. And we started doing this in the front seat of people's cars. Why? Because initially during COVID, that was the best place to take a COVID test. People were protected from everyone else, isolated in their vehicle, roll the window down, swab them, roll the window back up, give them their result in a day or two, and they can do what they need to do from there. But we started proving out this idea that we could do mass hypertension screening using mobile units. We did almost 3,000 people before we did this first paper on this in hypertension, and more than 60%, almost 63% of people had elevated or hypertensive blood pressure values, with more than a third having stage 2 hypertension. So we went forward with it here, started publishing things on new systems of care, started validating this blood pressure measurement approach, doing a clinic office triplicate measurement, a car triplicate measurement, and a clinic measurement to see what correlation, and we found that it's quite accurate and correlated quite well. We became known for this type of stuff. This is James Young, one of our lead research assistants, who got interviewed for the Wall Street Journal because one of their reporters attended a talk I was giving at American Heart Association on this. And you know, we've really started to move the needle forward on better blood pressure measurement using measurement and management using protocols like this, and started publishing on this stuff, started to say, hey, we're on to something here, that while we don't always know what exactly happens after the person comes through, unless we follow them up or in one of our research protocols, we do know that if somebody gets a blood pressure measurement in a mobile unit and then gets a subsequent one at a later time point, the subsequent one is typically lower, and lower by almost 16 millimeters of mercury systolic. So whether that person is changing their lifestyle or starting to take their medications or went for a follow-up physician visit, we're starting to see that positivity. And where we're at now is we have now incorporated multiple different mobile units. Like I said, I'll talk about that in a second. And in total, this is our evolving dashboard since we began in March 2020 up to just a couple of weeks ago. We have almost 125,000 visits through various different programs. Most of these are ours, but we're able to show things like for people who come to the mobile unit at different time points and have multiple measurements for whatever reason, whether we're following them up or not, we see a very nice downward trend over time in blood pressures. We see the same thing when we do average lab values like cholesterol or LDL, triglycerides, things like that. And we also are able to come up with very unique metrics where going forward, we're talking about how do you use population level data to show that at a community level, you're dropping systolic blood pressure from an average, or tracking things like a median hemoglobin A1C in a community, right? Here you could see some of these darker spots. The median A1C in that entire community is somewhere between 5.9 and 6.1, which is not necessarily abnormal, but not necessarily good either, right? That's in the pre-diabetic range. And so you have an entire community whose average A1C is pre-diabetic. We can look at average EGFRs, right? We have communities where people on average in the entire community have stage 1 or stage 2 chronic kidney disease, and the same thing with cholesterol, right? Although these numbers aren't as high necessarily when you take the average, you have some areas where the median total cholesterol is above 200, which is kind of crazy. We're also able to do other things like look at where there's drug overdoses and where we can target Narcan distribution kits. We are submitting a grant any day now called IC, which is looking at visual disturbance, and we're able to overlay targeted outreach from mobile units with people who self-report vision disability as an important metric. And so the reason I'm setting up all this backdrop is just to give you an idea that we are very much of the mindset data matters, and data can be used for a lot of different things, and have created a data environment that we use specifically through the initial lens of the pandemic, and now moving forward towards a vision of portable population health to do better things for our population. And I showed you the first Racial Disparities Task Force report. There was a follow-up one that came in the second year, where there was recommendations to continue funding from direct appropriated dollars in the state budget, not CARES Act that was coming through from COVID, but appropriated dollars to continue building out infrastructure. And here's where that was signed. That's Big Gretch, our governor, and even bigger Lieutenant Governor Garland Gilchrist, who's 6'7", and a wonderful guy. But what was included in this bill when it was signed a couple of years ago was $49.5 million to put forth continuing efforts around racial disparity task force recommendations, with $7 million to continue mobile health unit infrastructure, which we oversee. We've gone from there to expand the mobile health infrastructure to have 11 programs with mobile units in something we call the Michigan Mobile Health Corps. And again, the key point in all of this is now we have a deployable resource that we can leverage data from things like Phoenix going forward. Phoenix continues to grow and get significant users since we launched the updated website in September 2024. So, almost a year ago, with the more refined website, we've had almost 2,200 users, a lot of new users, a lot of page views. As you can see, a lot of engagement around all of this. And then, we just track metrics. It's interesting. People on a Wednesday are most happy to use it for whatever reason, but we can see the basis of where people are using Phoenix, and how often are they there, and then how much time are they spending in that location, and obviously other trend analysis that we can look at. But what I wanted to talk about in the last portion of this is how we're now using this to tackle something that we all know quite well, the community health needs assessment, and reimagining that as now a data-driven AI-generated process. So we call this CHNA 2.0, and it developed out of a process between the city of Dearborn, Wayne State University, and the Google Cloud team with Centasa, who is one of the Google Cloud service providers. The city of Dearborn entered into a very unique contract with Google to develop its IT infrastructure, and they wanted to develop a data warehouse. And in that data warehouse, they wanted to have one common location where they can put all manner of different data that's proprietary to the city of Dearborn, dog bites and power line, downed power lines, or EMS runs for various conditions, and try to understand what factors may be contributing to those conditions. And they came to us and said, well, there's no point in us reinventing the wheel. Why don't we integrate data from Phoenix so that we can get better understanding of our neighborhoods? And at the same time, they said, we are embarking on doing a community health needs assessment in the city of Dearborn. They created a new public health department. They did not have to do a CHNA, but they wanted to do it. And we said, well, wouldn't it be great if we compared a CHNA that you're doing in a traditional manner where you outsource it to an entity who goes out there and pulls data from CDC places and other things to get prevalence information, and then goes out there and canvasses the community and gets survey data, and you derive, the typical white paper that comes out of a CHNA, that, I hate to say to anybody who does them on the call, often is the same type of stuff over and over again, right? People identify needs in the community. They talk about barriers and access issues. And a lot of times it's, the same thing over and over again without much of an effort to really try and change it. Implement change on top of that. We said, wouldn't it be great if we could do this in a much more streamlined and automated manner? The one thing that the CHNA does is incorporates the voice of the community itself, and we were questioning how could we do that with the information we had. Enter Sintasa, who's a company that was working during the pandemic on sentiment analysis, scraping data from search engine information and social media feeds to try to understand from a vaccination perspective, where was the sentiment in communities around getting vaccinated or not? And that's important when you think about deploying resources to areas. It's going to be a lot less fruitful if you target a community that is not interested in what you're bringing to them. In this case, we know vaccines initially weren't and then became quite contentious around COVID. And you had communities where they just were not going to get vaccinated no matter what you did, and others that really wanted vaccination. And understanding those distinctions is a really important way to think about how things can be, brought about. So we started to imagine and said, couldn't we do an AI generated automated CHNA with this process, incorporating some of these thoughts? And if you think about this, the CHNA involves assessing needs, it's highly manual, it takes time, and could we transform this into something that would be much more data driven? Ultimately, our vision is to have the CHNA be a dashboard thing where you get constant updates on an almost daily or weekly basis of information, so that you're actively managing the real community needs. And I always say that any CHNA that was done in January 2020 was obsolete within 2 months. And we know that's the case with other things that are evolving. So could we think of this all very differently? And so we took this to say, can we develop timely insights with AI-pruned dashboards, contextual explanations, actions tied to insights, and informed choices much more quickly, and empower public health to move forward? So we thought of this as CHNA 2.0, community partner in Dearborn having their own data, academic partner having Phoenix, and then Sintasa serving as a solution partner, where we could take different data feeds, mix them together in a consolidated data aggregator like BigQuery, and then apply AI tools from Google like Gemini on top of it to derive insights, and actually, in the end result, derive the entire CHNA in an AI developed manner. So we did that, and within 3 months from the sprint time, the entire thing was completed, a 41-page beautiful document that incorporated a lot of insights. And so Dearborn has 9 primary neighborhoods, and we were able to incorporate things from Phoenix, like life expectancy in different neighborhoods, hypertension rates, blood pressure reporting, elevated blood pressure versus hypertension, it's a distinction, poverty, Gini index, unemployment, population densities, other information like neighborhood factors, right? Life expectancy, water quality, crowding, air pollution, things like that. Incorporate data from Dearborn on EMS runs to different areas of the community. Add in social media data. What are people looking for and what's being reported in top themes over different areas in social media? Doing word maps where we can look at what are the primary things that people are searching for, above and beyond other components. Starting to incorporate Google search data, right? Search trend data, but doing it in a way that it will allow us not for an entire state or a county, but for city level to get at things like Dearborn, which is right next to Dearborn Heights, which is right next to Detroit, and looking at what are people searching in the community. We were really surprised to find childbirth to be a very big search thing. But you see just one community over, religion, very important to the Arab American community, but things that are consistent and somewhat different. Now, this is done by defined search terms being applied defined terms being applied to search trend data. And so you can, mix and match different things. But if you look in the city of Detroit, which has a lot more social vulnerability, you could see things like hospitals and food stamps and fentanyl and homelessness popping up where they weren't in those other areas. And then you can map this out, right? And you can start to look at where are communities looking for things more or less. And that can get, and Dearborn is down right in this area over here. And obviously Detroit, like it says right here, and you can look and see where are communities interested in this information. And then you can break the community down by their boundaries, like I said, for the 9 neighborhoods. And then what was derived was identified health needs with an AI generated summation for each one of these individual neighborhoods. And so we really felt like we were onto something. And so now we are actively working with public health departments across the state, across the country, to think about how can we bring this type of resource to them? How can we reimagine the CHNA process from a static, every few year, document-driven white paper output thing to a dynamic dashboard-driven thing that's informing communities in near real time about what's going on in their neighborhoods. At the same time, all of this is going on, we were really interested and are interested in applying this still to our continued problem of understanding how to get into communities and neighborhoods to do better public health for different areas. We started working with payers. And one of the first things that we did with payers was said to them, well, what can we help you with? And Molina is the largest Medicaid managed care entity in our area, 90,000 covered lives in Wayne County. And Molina came to us and said, we'd love you to help us find and treat our uncontrolled hypertensives. We said, wonderful. How many do you have? They said, we have 5,000. I said, you cover 90,000 lives in a predominantly Black, underserved population. There's no way you only have 5,000 uncontrolled hypertensives. We said, how many, how do you become an uncontrolled hypertensive in your world? They said, you need 2 office-based HEDIS blood pressure measures. I said, oh, that's good. How many have 0? And it was 40,000 people. So almost 45% of their covered life population was not getting blood pressures and not getting screened each year. And we said, well, why don't you give us that data? Let us map it out across the region. So we look at densities where people are not getting care. And so we could really rethink this process and identify what we call ghosts in medicine. People who don't engage in the health system, but we know they're at risk for problems because they live in communities that are high risk themselves, so that we could start to target deployment of resources to these communities. And now we're continuing this work by working with Medicaid payers to look at what we call HEDIS metric gap closure. So we know that from a quality perspective, HEDIS metrics are the way Medicaid managed care plans get paid, the way they are judged for what they do. But a lot of times they have quality metrics that are very difficult for providers to achieve. And keep that in mind, right? A payer pays providers to do care for a covered life population. And so they want providers to do things like do annual wellness visits and get blood pressures under control. But the provider is only able to do what a patient is willing to do with them. And the plan itself is the one who is ultimately held accountable for that outcome. So they try to squeeze the the providers as much as they can. We said, no. Let's think of this very differently. Why don't we fill a gap in the middle here where you have patients who are not achieving their HEDIS metrics, and we can deploy resources to go down that road. And we're working very diligently on this right now. Again, that's not necessarily an AI-driven component, but the next piece is, because I think you'll see the relevance. But what we also started to realize is that, yes, it's really important to get to these underserved populations who are Medicaid recipients. But when you look at who gets healthcare from what payer, the majority of people who are eligible or would likely benefit from better control from a prevention lens, younger individuals who are less than 65, not saying above 65 is a bad thing or that they don't need care. They are just generally either already getting manifestation of things that are preventable complications of things like hypertension, strokes and heart attacks, and what have you. So if you're looking for prevention, you're looking at younger populations, right? 35, 34, 50, whatever it might be. The majority of coverage for healthcare for those folks comes from private insurance, not from Medicaid, or whatnot. And, in our state, for example, Michigan, 51% of the entire state gets coverage by Blue Cross Blue Shield. So they're by far the largest payer for healthcare in the state, for the largest swath of the population that's likely to benefit. So we need, if we're going to start to move the needle overall on health outcomes for our community, we need to get to those individuals as well. And oftentimes, you guys know that even if you have insurance, it doesn't mean you don't have social vulnerability. It doesn't mean you're making a full wage that's covering all your costs in life. And we know there are plenty of people, especially here in Michigan, the manufacturing capital of our country, plenty of people in Michigan who are working jobs where they get paid, by the hour, even though they get coverage for their insurance, and they're not going to take half a day off and leave work to go get a blood pressure check when they're 40 years old and feel just fine, even though they may have hypertension. And so we started to say, if we want to reduce disparities and improve life expectancy across the region, we can't just focus on Medicaid populations. We have to focus on all patients, especially the big bulk of where we can make benefits. So we started working with businesses, and we started working with manufacturers, companies in the Ford manufacturing ecosystem. Detroit Chassis makes bus chassis for Ford, and they worked with us to bring on-site services to their employees, recognizing we go to where people are. And we started developing a concept of preventative health and on-site wellness clinical services, doing screening at a fixed rate and bundled rate for care, adding on different components, creating opportunities for what we call per member per month pricing for ongoing care. But every time we brought this up to a business, to Blue Cross Blue Shield, they always came back and said, well, what's the ROI? How do we know the benefit of what we're doing? So the most recent iteration that we've been working on with AI with our Phoenix team is coming up with an AI-driven ROI engine. And as you can see here, I'm going to run through a lot of this. This will be in language that I think the AI folks on here will really appreciate, but trying to come up with an animated hexagon map approach with disease filters so we can aggregate real-world data by scraping news, research articles, court and congressional hearing reports, social media, Google Trends, and creating a per hex health signal strength and ranking top conditions per location, and then focusing on absenteeism based on these conditions. Can we target a cost per employee of absenteeism to convince them to invest in better prevention services? And so that's where we've moved forward and provide defensible ways and automated pipelines to show them the value proposition. Our end-to-end pipelines involve automation with ingestion and transformation and geocoding and, as you could say, scoring based on per source normalized data with time decays and weighted blending, and then maps with hex grids that allow us to look at all of this using fast API endpoints and whatnot going forward. And so we're at the point now where we're developing for different disease states weighted variables per hex per disease, like I said, and applying this so that we can look at a region, go over an entire region where everything is broken down into these hexagon shapes, but it's overlaid on top of mapping. And I don't have the ability to show that right now because it's still in developmental stages, but I'll show you in a couple of slides where all this is going. And then we can come up with absenteeism cost per employee, looking at various inputs and computer weighted prevalence for disease, and come up with a calculation for annual cost per employee. And we started with some base cases of hypertension, diabetes, opioid use, depression, obesity, and asthma. This is just the beginning, not the end. And we're going to be actively working on trying to figure out what is the base day consequence of absenteeism for these conditions, ultimately with the goal of ingesting and incorporating a given business's information on absenteeism so we can better understand the impact and the benefit of improving outcomes related to this. Our architecture and stack involves Python, Playwright, as you can see, processing with various different tools using Gemini, as was mentioned. Our storage is all sitting in Google Cloud Platform. And as you can see, we have a whole bunch of other components. And basically, the output is something like this. Again, overlaid on maps, everything can be based onto a hexagon component, again, still in developmental stages. But what we're able to do with this information is something like this. So Wayne State University, where I work, for depression, hypertension, asthma, obesity has an average cost of about 1.415 million per year in health-related absenteeism, a cost per employee of about $1,200, and potential savings of almost $400,000 with better prevention screenings. We can incorporate things like where people are coming from, commuting analysis, making sure that we don't overestimate one community's impact versus another, looking at top health concerns based on what we see from our scraping of various information sources and tying in a risk level related to the employees that come from that area, and come up with sentiment analysis in terms of what Twitter, Instagram, Facebook, and other things are saying for things that could impact those outcomes. Rocket Mortgage, a huge employer here that is Dan Gilbert's company. Some of you may know the name Dan Gilbert, but here their estimated cost almost $6.5 million, about $1,500 per employee, with savings of almost $1.8 million. Again, focusing on those same things with the same type of components of where their employees come from, the same type of sentiment analysis. And then last but not least, Ford Motor Company, the headquarters, which is based in Dearborn, same type of thing that we can do with the same type of components, all AI generated. And ultimately, our goal for this is to have maps like this that are broken down to hexagons where you can gloss over each one of these areas and you can get information on the businesses in those areas, and each business you would gloss over, you would have the cost per absentee for absenteeism estimated. And if we're able to get actual absentee data from the company itself, which would be part of our conversation and negotiation, we can actually get real cost analysis for this. So here just shows different business densities in communities, employee density scores, right? The total number of employees per area. That helps us figure out if we're going to deploy resources to communities, where's our biggest bang for the buck? Where are we going to be able to do the most in one day? We have a program with 9 mobile units, but we partner with, like I said, 10 other programs now, and we have about 25 units across the programs that can all be deployed in a collaborative fashion, particularly if we're able to get reimbursement from businesses for the work that we're doing. We can also look at things like foot traffic potential. So not only the business itself, that are there areas adjacent to businesses where we can be helping businesses out, but also capturing foot traffic from people who live in those communities. And then finally, you can think of all of this being integrated into a hybrid type of score. So that's my email right there. We're happy to talk about any of this offline or give demonstrations for anybody who wants them. Happy to share these slides as well. But what I really wanted to walk through here, yeah, absolutely, Tina. I'll pop it in the chat. It's plevy@med.wayne.edu. But it should be up there still, but if it's not, I'll pop it in there. But we're happy to go over this with you guys, happy to talk this through for your individual communities, happy to work with you guys to incorporate Phoenix data feeds for your own states, right? Like I said, right now we're Wisconsin to Massachusetts, but it doesn't take us a lot to add on other states because all the data exists in the background anyway as we start to scrape these components. At the end of the day, what we're really trying to do is reimagine how we can deliver population level interventions to improve public health outcomes like heart disease and prevent people from dying younger than they should. So I'll stop there. A lot to throw at you guys, but I really appreciate the opportunity.